Yes, it's an interesting title. Good morning, everybody. I hope you get out of this day what you all hope to achieve and that you leave knowing a little bit of what we're all doing. Who gets what and why is an interesting thing. Some of the slides will be repetitive during the day. I don't think you should be too worried about that because the message is always the same. We're trying to make sure that everyone recognises this is a condition that we are dealing with. If I tell you that I started doing neurosurgery in 1980, and when I got a referral for someone with brain mets, I put the phone down. Sorry, nothing to be done. And that was just it. That's how it is. And nowadays with the way that the disease-modifying drugs, the new treatments that are coming through, and the chemotherapy regimes, as Catherine's just pointed out, we as neurosurgeons are getting more and more referrals in, quite rightly, for people with brain metastases. And if you think, if between 1 and 2 or 1 and 3 in the population will get cancer, and that between 20 and 40% of those, i.e. about a third, will get brain metastases, and we serve a population of just over 3.4 million, then roughly 350,000 people out there may get a brain metastasis at some stage. That's just for the Greater Manchester Neurosurgical Unit. So it's a huge change in work practice. Not all of them will obviously need our attention. Catherine's just pointed out that, with systemic cancer screening for various trials, we pick up brain mets and they can come into us. And what I'll talk to you in this lecture is really how people come in, how you might choose to refer people into us, whether it's directly to the neurosurgeons on call, whether it's into the MDT, or whether it's via the treating oncologist. Because I think that's really what I want to leave you with the message at the end of this 15-minute chat. Don't forget they bleed, so they do come to us acutely, melanomas in particular. And we do get people with hormone dysfunction because the pituitary isn't immune as a site of a metastasis. People often look at a scan and think, oh, that's a pituitary tumour. And actually it isn't, it's a pituitary metastasis. So these are all the things that we're now really taking account of. And I've just made that point about there's potentially over 350,000 people who might be suitable for referral. Those are really the treatment options. So when the title says who gets what, when and why, you're really down to those things. So nearly all the people, when they're diagnosed with a metastasis, will be put on steroids. That's to reduce the edema. And the great thing about metastases, when you look at them as a scan, is for the tiny little dot, and I don't know if you noted that with Catherine's slides, but even with the tiny little dots, there is a dark area disproportionately surrounding those dots, and that is brain edema. And brain edema is bad brain. It doesn't function well. It fits. It doesn't move things that it's meant to do. It doesn't interpret and have cognitive function in the way that it should do. And steroids dramatically improve that. The anti-epileptics, if they presented with epilepsy, then we put them on it, because the role of anti-epileptics is to reduce the likelihood of having another seizure. Do we put them on prophylactically when someone comes in as, say, picked up on a routine systemic disease screening program? No, we don't, not as a uniform action. And you may say, well, why don't we put them on anti-epileptics if it's in an eloquent area like the frontal lobe? And the answer is, well, there's a big debate, and it's been going on since I started neurosurgery in 1980. No one can make their mind up as to whether or not it's the right thing to do for a patient. It doesn't affect their driving restrictions, because, of course, if they have a metastasis, they can't drive anyway. And it's something that we argue about. But anyway, if they've had a fit, they get anti-epileptics. If they're going for surgery and they haven't had a fit, they do not routinely have anti-epileptics. But a lot of these people will need analgesics because they've got headaches. I'll talk about the surgical management later, and then we've got the oncological treatment, and that will include the chemo therapy for certain ones. As Catherine pointed out, a few of the modern drugs will cross the blood-brain barrier, but it's the blood-brain barrier that makes life difficult for treatment of all cancers in the brain, whether primary or, in this case, secondaries. It is a remarkable barrier, and it just stops the larger molecules from getting across. Radiation, obviously, whole brain and SRS, Jill will be talking about, and I don't want to steal her thunder. I think as a sort of quick guide, that really sums up who should have surgery. So even this is changing. The role of who gets, for example, stereotactic radiosurgery is changing, and it's now down to total volume rather than actual size or number. So where we used to say, well, if it's greater than 3 centimetres, we'll take it out, that's not necessarily the case anymore. But if they've got pressure effects, if they're in a non-eloquent area, i.e. not slap bang in the middle of the motor cortex, then we would take it out. If they've got obstructive hydrocephalus from compression, for example, of the third ventricle, you're not going to take it out. But if they've got hydrocephalus because there's something in the cerebellum blocking the fourth ventricle, am I keeping you there? Do you understand how the CSF pathways work? That you have the two lateral ventricles which come into the third. The trouble is, on either side of the third are vital motor organs in the brain, the thalamus and the basal ganglia. And so you wouldn't take something out there if it was causing an obstruction to the third ventricle. But lower down, where the big cerebellar hemispheres are, they can obstruct the fourth ventricle, which blocks the whole lot. Now, when they get hydrocephalus, you can take them out of the cerebellum because it's not as eloquent. And that's the point. If you don't have risk of damage to the patient, you will take the tumour out. If they've had radiotherapy, and sometimes they get swelling, well, always they get swelling, but sometimes it's clinically relevant, you may be forced to a situation where you have to remove the necrotic tumour. And also if they've had radiotherapy in whatever form, but the tumour's progressed or recurred, you may then say, well, I can't give any more radiation, so then the surgeons, if they think it's appropriate, will take it out. Why do we take it out? Well, if it's a big lump, it's going to have mass effect, and if we can reduce that, the brain may function better. It releases the pressure effect either from obstruction to the fluid pathways or directly on the brain. And we know that they live longer with surgery to take them out than leaving them in, although at the moment the trials would suggest that surgery is probably about the same outcome effect as stereotactic radiosurgery. But we only do that if the disease systemically is actually controlled. And I think that's the other major message, that where the disease systemically isn't controlled, the role of surgery in brain metastasis management is limited. So there's an example. This is a fairly large tumour. It's cystic. What's happening here if I don't press the right... There we are. I won't bother pointing. Which one is it? I pressed that one, it didn't work. Oh, well done, you've got the right pressure. Large cystic lesion, solid component, solid capsule, but a lot of this peritumoral edema here and shift of the midline, which is resulting in the other side ventricles, these black cavities here, being much dilated compared to the normal size. So if you do have that on your scan, then you take it out. That, on the other hand, sitting in the corpus callosum, it's deep in, you know you're going to leave the patient damaged. It's a small target. Yes, it's got a lot of edema around it, but you would say that should be sent to our radiotherapy colleagues, and they would elect what type of treatment to give. You can argue about these, and of course the point about lesions in eloquent areas of the brain is it's not the neurons, it's not the actual nerve cells that you risk damaging that damage the patients, it's the tracts. And we're recognizing that more and more as we do more and more awake craniotomies for surgery. So more and more for intrinsic brain tumours, we're doing the patients awake. And what we recognize is it's not the damage to the surface part of the brain where everyone knows the cells are, the so-called cortex. But it's actually the fibres that run down in these things called tracts that run through the white matter. So there is an argument sometimes for taking surgical lesions out, even though, for example, in that case, that might be just close to the sensory cortex. It might be the part behind that sulcus that Catherine was talking about, the bit that divides the frontal part of the brain from the parietal part. Anyway, you could make an argument, although that's quite a large one, for giving radiotherapy. Same for that, it's smaller, but you could argue you could take that out. And the same with this one. But the point I'm making, and this is just a CT, is look at the surrounding edema in relation to the tumour. It's more than you often expect for the size of the target. So those are our treatment options that we have to make a decision on. They're all options that are on the table, and they're usually options that we discuss at the MDT every Tuesday, but I'm sure they go on in every MDT in whatever whatever cancer specialist that MDT is deciding on. It's got to be a joint decision. You know, when you go back to the patient and the family and say, look, this is not for treatment, your best palliative care, they want to know that it's not Joe Bloggs made that decision, that actually a lot of people have put their two pennyworth in and come up with the answer that's best for that particular individual. So firstly, it's at the site-specific MDT, and often made by the treating oncologists and their teams. The neuro-oncology MDT make those decisions and recommendations. For our own patients, we make the decisions, but for people who've been referred in for an opinion, it's a recommendation that we send back. And it's going to involve the patient and any other clinicians that are involved in their care. So how do people come in? Well, firstly, a lot of people come into the neurosurgery on call. And when we look at our MDT each week, we have a section of on-call referrals. And in that, there used to be a large number of metastatic tumour patients, to the point where we've actually separated them out, and we now have a separate section of the MDT which deals only with the metastatic referrals. And they tend to be the tumours who present either hemorrhage, particularly in the melanomas, for example, or where you've got a single tumour who's producing a mass effect, and they presented with fits or with a deficit. They've been scanned in the peripheral hospital, and they get referred into the neurosurgeons on call. What are the other referral pathways? If they've been treating as part of a trial, or if they've had their general cancer treated with their oncologist who's done a scan, they've picked up brain mets, we know they've got a known cancer. They may have multiple mets, and in which case they come into our MDT. They may be an unknown cancer, in which case they need to be investigated and referred on after discussion at our MDT back to the oncologist for the unknown cancers at the treating hospital. Or they may be a single met, but with a known cancer. Again, treating oncologists and then into us. So these are the sorts of pathways that we're going to be putting into practice, and indeed is working at the moment. So we're going to go through the known and the unknown, whether they're single or multiple, and whether the disease is controlled or uncontrolled. And that will determine where the outcome of that patient's recommendation for treatment is. Now, I think, don't get confused by all this. You've got it in your pack or in the supplementary add-ons that you get at the end of your talks. A known cancer, okay, CA breast, CA colon, whatever, multiple metastases, but the disease isn't controlled. Okay, we're not going to do anything because it's an uncontrolled systemic disease. We don't know what that patient's prognosis is. So we refer back to the treating oncologist. They don't need to be referred in directly to the neurosurgeon. Now, the referring oncologist may look at it and say, it's uncontrolled disease at the moment, we think we can get control, it's a single met, in which case we'll come back to you. That's fine. Everyone can come back for a second opinion. We've got a known cancer, uncontrolled disease, but it's a solitary metastasis. Again, it's the uncontrolled systemic disease that determines the pathway. Go back to the oncologist. They can come back to us and ask us to review that if they feel that there is a prognosis. So, for example, if they think the patient has got uncontrolled systemic disease but may live for more than 6 months, it's a solitary metastasis, it's in a reasonably available area for either a treatment with radiotherapy or with surgery in terms of the superficial, non-eloquent part of the brain, we may actually carry out surgical resection. But it's the treating oncologists of the primary uncontrolled systemic disease that will give us that advice of prognosis. We've got a known cancer, small number of mets, and we're not sure, is this disease controlled systemically or is it not? Well, we have to talk to the treating oncologist. Back the patient goes, unless they've got serious mass effect. And without surgery, their prognosis is a matter of days or even weeks. Well, then the neurosurgeons need to get involved, because it's actually important to take that mass effect away. And the one thing about that is radiotherapy may actually increase or worsen the mass effect, whichever type of treatment you give, whole brain or SRS. And we often have discussions about whether or not we're going to make the patient worse temporarily with radiotherapy, or whether the risk of taking the lump out and giving them a deficit would justify that. No known cancer, unknown primary. Small or a single metastasis, they need to be investigated. Worked up, CT chest, abdomen and pelvis, look for what may be or may not be present. Negative CT chest, abdomen and pelvis, they need tissue diagnosis. We're often asked to give that, and that may mean excision or biopsy. So that is the way of diagnosing where the likely primary site is. It's not always foolproof, but at least it gives the treating oncologists of the unknown primary an idea of where the tumour may have come from that's given rise to this single or small number of brain metastases. Again, referring back to the appropriate oncologist. I'm going to stop there, because otherwise I'm going to stroll over into SRS territory. But basically that is where the radiation oncologists and the neurosurgeons are now starting to have more and more interaction in terms of what is the use of SRS, whole brain radiotherapy, when do we use it, and what are the contraindications to either aspect of treatment. So I hope that gives you a little bit of who gets what, when, and why. But please ask any questions you have. Have we got time for questions now or later? Which would you rather?